So either way, I can find my screen. There we go. So can y'all tell me what micturition is? What is that?
Is that just urination?
It is. Yep. It's that release of urine from the body. That's as simple as that. Same thing. It's going to the bathroom. The presence of what in the urine might indicate a disease or malfunction of the urinary system?
Blood.
That wouldn't be a
Protein.
Bacteria?
Foam. The presence of.
and that's why I love we're going over it. Yeah, those are not necessarily indicator of malfunction, but some of those could say infection or an issue. And the answer that I will be looking for is protein. We don't want any protein in the urine. So the presence of protein in the urine might indicate a disease or malfunction of the urinary system. And then I started wondering, I can't remember if we went over a 24-hour collection of the urine. Was that on one of my videos? Briefly? I really didn't
remember anything.
I really didn't think it was. I could not remember, and I was going to go back and look at it this morning and did not. In all transparency. So I wanted to just I threw this in there to talk about it a little bit. The 24-hour collection of urine is the primary test of renal clearance used to evaluate how the kidneys perform. So yes, we check their creatinine. We can check their BUN because those are other forms also, like lab tests. That's via blood. But for urine purposes, when a doctor asks you that we need to do a 24-hour collection. So what that means, I get this big old orange jug. Have y'all seen those before?
Yes, ma'am.
Some of y'all have? Okay. So you get it's a big orange jug. And when you're teaching this to the patient, what they're going to do is go to the bathroom in that morning and they're going to discard that first void. Okay. So, but we're going to start that time at that time. So whenever their first void is, say they got up at 8 o'clock, they voided, we're going to write 8 o'clock on that bottle, but we're not going to put it in there. We're wasting it. But every urine after that is going to be collected and put into that big bottle. Okay. And it's going to be collected until 8 o'clock that next day. Not 8:05, not 8:10, but 8 o'clock. So if they peed before that, great. If they didn't, too bad. We still let it at 8. And then we take it back to the lab. Something I didn't stick on the slide, but another thing is it needs to stay cold. So we usually put it on a bucket of ice, or you can put it in the refrigerator, either way. Because again, bacteria grows in urine very quickly. So keeping it on ice. But the main thing is going to be the time thing. So if somebody got up at 6 o'clock, are we going to get that first urine? Nope. We're going to waste that first urine, but we're going to start the timer at 6 o'clock in the morning and continue to take it until 6 o'clock that next day. Anybody have questions on that?
No, ma'am.
No.
All right. A patient's vomited for a couple of days. What findings in the urine would indicate that we might need to increase the fluids? When we are visualizing whether it's a Foley or they've gone to the bathroom, what are we thinking the color is going to be?
Dark.
Dark. And if their specific gravity is still going to be what? What would it be above?
Is it 1.0? Is it 5? No.
Yep. 1.025 or 1.030 is going to be the higher end. So if it's above that, that means they're dehydrated. If it's below 1.005, then they're overhydrated. Okay. But that urine, if they've been sick, they're dehydrated, that urine's going to be dark. So some different statements that are true about cancer of the kidney. And I went ahead and put some questions up there so y'all kind of be getting an idea of what we're looking for. So kidney tumors, what age? Are they rare in people under what age?
30.
30.
30, okay. Are they usually benign or malignant?
Malignant.
Kidney, yes, tumors are usually malignant. And they occur more frequently in men or women?
Men.
Yes, more frequently in men. Think of that benign, their BPH, prostatic. Occur more frequently. Oh, I already asked that one. Have increased incidence in people over what age? So 30
65.
and then over 65. Okay, they're at an increased risk. And then is it aggressive? Is renal cancer aggressive?
Yes.
Yes, it usually, because the kidneys are so vascular, it usually invades the aorta or the vena cava. So it usually spreads very quickly. All right, so nurse should educate patient to perform daily what to treat urge incontinence?
Would that be Kegel exercises?
Yep, Kegel exercises. That's what we're going to be doing. All right, so I did go over this on the video. Correct sequence order in collecting a clean catch urine specimen from a female. So the first thing you're going to tell them to do, and sometimes you actually have to tell them how to collect the urine, or it's not going to be a clean catch. There's going to have contaminants in there, skin contaminants. And as y'all know, we all have germs on our skin, right? Even down there, even with that acidic stuff, it's still going to be contaminating that urine. So what's the first thing we're going to tell them that they're going to need to do?
Wash their hands.
You can have them tell them to wash their hands for sure, but I mean, hopefully, I always give them gloves as well. But we're going to ask them, they're going to have to make sure that they spread the labia apart, okay, to expose that urethral opening, even when they're doing a clean catch. So that's why I usually give them gloves. Then you need to tell them, because they get 3 wipes. It drives me nuts when somebody gives them 1 wipe, because that's not enough. Think of when y'all are putting in the Foleys even. Y'all have to wipe 3 times, right? So it's kind of the same concept. Spread the labia apart. Use the first sterile wipe to clean the inner fold on one side, front to back, and then the second wipe to clean the other fold, and then the third wipe to clean the actual opening of the urethral. Then do we tell them just to go ahead and collect it as soon as the stream starts?
No.
No, midstream.
Yep, midstream. We want them to go ahead and start their urine. So begin urinating in the commode, start their stream, and then while they're in the middle of urinating, then to collect it. Okay. We don't have to go in with them usually to go to the bathroom to collect this. So that's why it's our job to educate them so we can get the best specimen possible. Otherwise, it's going to come back contaminated, and it's hard for us to diagnose as well. We can still do a culture, but that takes 72 hours. So we'd rather have an idea if it's really needs to have an antibiotic before then. So that's the proper things to do. And that will be an ordering question. So spread the labia apart, first wipe, second wipe, third wipe, start their stream, and then collect it midstream. All righty. What test that uses urine specimen to indicate glomerular filtration rate in renal insufficiency? So this is going to be like a blood test. What's a blood test that we can get? Well, I can get it from a urine as well, I guess, honestly. Any guesses?
Is it the KUB?
No, it's going to be a lab. KUB is going to be more X-ray, and that's on here in a little bit, I believe. But so when we're talking about the GFR rate, the glomerular, I hate saying that word, glomerular filtration rate, the GFR. So that's how well our kidneys are functioning. The main test for that is going to be your creatinine clearance test. That's going to show us how well those kidneys, the nephrons, are actually filtering. And y'all are watching that video. I was really wanting to take y'all into our room because I had that anatomotage table for y'all to look at, and it actually shows the diagram of it going through the nephron and stuff. So, and then what occurs in hydronephrosis? We went over that very quickly on the last, maybe the last PowerPoint.
There's an obstruction that blocks the outflow of urine.
Mm-hmm. That's exactly what it is. The urinary is obstructed, so it's not able to come out. Depending on where the obstruction occurs, waste products accumulate in the kidney and it's backed up in the blood. And that usually will lead to the end-stage renal disease. So that's why any obstruction is very important and critical. Oh. What are some nursing considerations for a client post-cystoscopy?
Would one be for them to report if they have blood tinged urine?
Okay. And that is very important. How long do we suspect that would occur? Like for like nursing considerations, like they do need to report blood tinged urine for how long?
6 to 8 hours.
That's if they haven't gone to the bathroom in 6 to 8 hours. We usually
Could it be
anticipate that
24?
blood tinge, for 24 hours. Usually it should be getting better. But if they haven't urinated after a cystoscopy, after 6 to 8 hours after the Foley's been out or whatnot, then that's an issue. We always want to encourage them to drink fluids. So y'all are going to know that that's not the answer on the test because we want them to drink fluids. We want them to help flush any remaining dye out from their body. So if y'all see that answer, no, that's not true either. But the nurse should help also because after cystoscopy, there's pain down there, kind of like after having a baby and away. So one of the things that we can do as nurses is to offer sitz baths. Okay. That helps them to void easier and it soothes that affected area. Also with sitz bath, just because the trauma down there, sometimes they'll offer some like hydrocortisone spray for the outside if there was trauma on the outside of the labia. But usually as far as the inside, getting them to start their urine flow and stuff, we can do a sitz bath. So what's nursing intervention for a client that is preparing to receive intravenous palligram? What's the first thing if somebody were going in and was going to get anything IV or take anything? What are we going to ask, especially if it has dye in it? If they're allergic to what, or if they have any allergies? We want to know if they're allergic to shellfish or iodine. Okay. Before this, do you think that should the patient be NPO?
Yes.
They're having a scope done. So they need to be NPO for at least 8 to 10 hours, not just 4 hours, but it needs to be 8 to 10 hours, sometimes 12, depending on their GI function stuff and their kidney functions. The client usually does take, before this test, will take a laxative before the procedure just to eliminate gas and feces before they go in. And I think that's it on that. Okay. Anticipated tests that would rule out a possible kidney stone. Somebody said it a while ago.
Is it a CT?
KUB.
A KUB is usually what we start off with, kidney, ureter, bladder. X-ray, because that can usually show all the stuff in the abdomen. So it's really a good first screening. CTs are so expensive, and usually if we're doing a CT, it's going to be with dye to see how the blood and stuff's going through. But a KUB is our first test that we will do because they can do that just even in the ER, a quick little X-ray. So kidney, ureter, bladder X-ray exam will be the first thing. All right, client is at risk for what when nurses perform frequent catheterizations? What is at risk?
UTI.
Yep. Yep, and any kind of introduction of pathogens into that bladder. So urinary tract infections. But what is short-term goal objective for a patient with renal calculi? Somebody comes in with complaints of pain, and we think they may have a possible kidney stone. What's going to be a short-term goal? We all talked about goals, like when y'all are doing your care plans for nursing homes and things like that. First, we always do ABCs, right? Airway, breathing, circulation. And then what's another thing that we're going to monitor for? Because they're obviously having or experiencing pain. Yeah, renal calculi, it's a medical emergency to an extent because it's not coming out, but we're going to make sure that their pain is tolerable. Okay. The nurse should do what with all urine is suspected of renal calculi?
Strain it.
Yes, they are going to strain it, educate them on straining it. But also on the test is what can y'all strain it with? Do y'all know?
Gauze.
Gauze, cheesecloth, or a strainer. Okay. And then we're going to save all that material and send it out. Because if it's with the cheesecloth or gauze, I probably, with my horrible eyesight, wouldn't be able to see it. So, but we would keep it and send it to lab. What is an important discharge instructions to encourage patient to help prevent recurring kidney stones? What is a good thing to tell patients to do? Besides managing their pain, we're going to ask them to increase what?
Their fluids.
Their fluids, their water.
Increase their fluid intake. We want to flush that kidney out. It's just kind of lodged there. And if it doesn't flush out soon, they'll have to have something else done. So, yep, usually we encourage those fluids, especially if we know that it's moving. It's just got to come out. So increase the fluid intake. All right. So what is a pessary? What does it do?
It upholds a prolapsed bladder.
Mm-hmm. Yep. It's a non-surgical option for females if they have stress urinary incontinence. So it helps support the organs in the pelvis, kind of keeps it up. So it's not pressure down, blocking the urine flow. Nursing care for a client after urinary diversion surgery. What will need to be assessed for? So just in general, they've had a surgery, a urinary diversion. What are some different things that y'all would assess for post-surgery? Knowing they've had an epidural.
Protein in the urine.
They may have protein. We'd hope there's no protein in the urine. But, that is something that we would check. But we would
If they've had an epidural, would it be if they can feel when they need to void?
Mm-hmm. Yep. Anything with the epidural. So
I didn't hear the epidural part. My bad.
Yeah, that's okay. No, and I want y'all saying all the answers. Like, what would y'all do? So after they come back, you're going to be assessing their leg status. Like, are they awake? They're oriented. But other things that you're going to think of because they have had an epidural. If they've urinated like in the next 6 to 8 hours, but also how are their bowels? You're going to assess their bowels as well, especially with the urinary diversion, because to get to that, they're going to be moving bowels. They could have injured the bowels. So we want to make sure that they don't end up like with a paralytic ileus or anything like that. So it's very important after any surgery to also listen for bowel sounds to see where they're at, knowing they're probably asleep. But we need to make sure that they are moving, okay, even if it's slowly. What test determines how efficiently the glomerular remove the urea that results from protein metabolism? So creatinine's kind of part of it. We know protein's not supposed to be in the urine, but there is a specific test that will determine this as well. And it is the BUN.
I was just about to say it, but my mic wasn't working.
Dang it. You would have got it right. Yeah, the most common cause of elevated BUN is kidney disease. But other things that can cause that, if they have a high protein intake, diabetes, malignancies, and just improper protein metabolism. So that's just something that they will check for usually is the BUN, creatinine, all goes together with your kidney function. Primary goal for client with pyelonephritis. Somebody that comes in with pyelonephritis, what is a goal for that client?
Relieve symptoms.
Yeah, be painful and stuff. Our main thing that we want is to prevent further damage to those kidneys, okay? Because it could lead to renal failure. And that's going to be the thing. Because pyelonephritis, it does cause scarring. And it can just continually get worse, and it causes atrophy after some time and makes the kidney fail. So our job is we want to prefer that further damage. So whatever that entails, and following the doctor's orders, but we just want to stop that. We don't want it to lead to renal failure. All right, so y'all did go over the indwelling catheter this week, I believe. So I didn't talk a lot about it, but to maintain effective drainage, the client should keep the drainage bag what? Higher than the bladder?
Lower than the bladder.
Below the bladder. So doing so allows the urine to flow by gravity from the bladder to the drainage bag. I have had patients that home health, I could not get him to put his bag, because he was in a wheelchair, to leave it up in the wheelchair below his bladder, but not on the ground. It was either on the ground or in his lap. I'm like, sir. And he just didn't understand why he kept getting UTIs. He was a very stubborn man. He knew. He just chose not to. Yeah, I don't really have a whole lot on. Did y'all have any questions about the urinary catheter? Is that your favorite thing to do now? Guessing not. So what are the purposes of dialysis? Thanks, Samantha.
To remove poisons or toxins from the blood.
Yep, to remove any waste from the blood, remove excess water, and establish or maintain proper levels of electrolytes. So every time they go to dialysis, they usually will draw blood. They do a quick test to see what their electrolytes are, whether there's too much potassium, not enough potassium, same with the sodium. They try to balance all of those electrolytes out before they leave. Early symptoms of benign prostate hyperplasia. What are some early signs?
Frequent urination.
Okay, frequency, yes. What else? It's usually not that painful. That's not an early sign anyways of it.
Weak urine stream.
Mm-hmm. Weak and dribbling, usually, like they can't even get it started. Like they feel like they need to go, but weak and dribbling, and then oliguria. They may have hematuria, frequency, urgency, increased urgency, and then nocturia. And then what are some care considerations for end-stage renal disease? So their kidneys aren't functioning well. What is something that sounds so easy but that we're going to do for these patients to make sure that they're not retaining all this fluid? There's actually two things, but test purposes.
Maybe a sodium restriction.
Okay.
Dialysis.
And they can do dialysis, but something that we can do without an order. What is something that we can do without an order necessarily to see if they're retaining fluid?
Fluid intake.
Okay. How would we know if they have gotten too much fluid or not enough fluid per se?
Weigh them.
Weigh them. We want to know if more than 3 pounds are holding that fluid. So yes, we should take daily weights on these end-stage renal disease patients to detect if they're having retention or edema. And I agree, all of y'all's answers as far as the fluid intake, it should be restricted. The kidneys aren't excreting. So yeah, we shouldn't be able to just give them free fluid. But the way to monitor that also is with their weight. And then just some quick facts. The color of urine indicates how hydrated you are. So clear or light yellow urine indicates that you're well hydrated, and dark is dehydrated. I think you've got that part of it. The main purpose of the urinary system is to filter blood and the different kinds of processes there. The kidney filters 160 liters of fluid a day. That's so much, but only 1 to 3 liters, or we say 750 to 2,000 urine pass out of the body. So that's amazing how much it filters and then how much we excrete. It's mind blowing to me. And then 80% of all material that enters the beginning of the proximal convoluted tubule is reabsorbed before it even reaches the loop of Henle. So it's done most of its job in the nephron before it even gets to the excretion part. In a healthy renal system, the urine produced is sterile, but the urea found in urine is the same substance that is found to melt ice in winter. Fun fact. It's crazy to me. That is all I have for y'all today. I do encourage y'all now, if y'all have any questions now that we've gone over last week's and this week's stuff. I know a couple of people had emailed me about questions, but I encouraged y'all to go back and look at slides and things before I just give y'all answers. I do anticipate y'all to do a little bit of the legwork. But do y'all have any questions?
I don't, Miss Sanders.
No.
Okay.
No, ma'am.
Well, if it comes, and I know y'all's test is on Tuesday, but if y'all have any questions, I will be out of pocket probably until Monday afternoon. I will try to answer if y'all have a question over the weekend, but I know the cell service is going to be very spotty. So it's not that I'm ignoring y'all on purpose. But if y'all have a question, reach out to a friend as well, or I will get back to you as soon as I can on Monday, or y'all can get with me Tuesday before the test even. Okay?
Yes, ma'am. Thank you, Miss Sanders.
You're welcome. I hope y'all have a great weekend. Try to enjoy some of it.
You too, Miss Sanders. Have a good weekend.
All right. Thank you.